Everyone, and welcome to Life and Breath Foundation's monthly educational webinar. My name is Sarcoidosis. It's an honor to host tonight's webinar. Our topic tonight is immunosuppressive treatments used in sarcoidosis. We're very fortunate to have with us Dr. Kristen Mathias, an expert in the field, who will share the latest insights. Before we introduce her, let me just, for those of you who are not familiar with Life and Breath Foundation, just give you a brief background. The reason we exist, our primary goals are to offer sarcoidosis community effective tools to track their journey, decipher medical issues, maximize the quality of life, to provide a nurturing environment for those affected with sarcoidosis, to build more awareness within the medical community to help combat the chronic disease and hopefully find a cure. What we do, we're a volunteer-led organization. Everyone is a volunteer, even the president of the organization. The money we receive through donations and sponsorships goes directly to support patients with sarcoidosis. Some of the services that we provide, we have monthly speaker series that you're actually attending tonight, patient support from sarcoid experts, patient support through sponsorships and education, my Life and Breath Planner. Any of this information is on our website, so if you want to learn more, please do follow us. Okay, to introduce our speaker tonight, Dr. Kristen Mathias is a physician scientist at the Johns Hopkins Sarcoidosis Center and Division of Rheumatology. She completed her residency in internal medicine at the University of Chicago, followed by fellowship training in rheumatology at the Johns Hopkins University School of Medicine. During her fellowship, Dr. Mathias also earned a Master's of Health, Science, and Clinical Investigation from the Johns Hopkins Bloomberg School of Public Health, and obtained certification in musculoskeletal ultrasound. She subsequently joined the faculty at Johns Hopkins. Dr. Mathias' clinical and research interests focus on sarcoidosis and scleroderma. In sarcoidosis, her work centers on reducing glucocorticoid toxicity and promoting early use of steroid-sparing therapies in patients with multi-organ involvement. In scleroderma, she is particularly interested in the early detection of interstitial lung disease and in developing tools to support complex decision-making for patients and providers. She sees patients in both the Johns Hopkins Sarcoidosis Center and the Johns Hopkins Scleroderma Center. And now, please join me in welcoming Dr. Mathias.
Thank you for that. Yes, thank you for that introduction. So let me just share my screen. Oops.
Okay, we got it.
All right, and it's advancing?
Yes, we are.
All right, okay. Thank you all for joining me. I am so honored to be talking today about immunosuppressive treatments and sarcoidosis. I don't have any disclosures, and my objectives today are for everyone to understand when you need immunosuppression in sarcoidosis, because just because you have a diagnosis of sarcoidosis does not necessarily mean you need immunosuppressive treatment. I will then review commonly used immunosuppressive agents that we use in the disease. And then I will briefly talk about treatment discontinuation, including how to monitor for remission and risk of relapse. But that's more for the scope of the question and answer section. I think I'm really going to focus on the first two objectives for the scope of this talk. So I feel like every speaker who decides to give a presentation about sarcoidosis shows some version of this picture, if not this picture itself. And I do think it's important to emphasize that sarcoidosis is a multi-organ disease, and it's also very heterogeneous. So your sarcoidosis does not necessarily look like someone you know with sarcoidosis or your loved one's disease of sarcoidosis. And so it's very important that treatment is personalized. Looking at the clinical presentation of sarcoidosis, I think most of us are fairly familiar with the idea that it can affect any organ system. Most commonly, it impacts the lungs, but it can also impact the cardiovascular system, the musculoskeletal system. And then on the left and the right are two images. One on the left is called Lofgren syndrome, which is a triad of enlarged lymph nodes in the chest, a rash called erythema nodosum, and then arthritis of multiple joints. And that tends to be a self-limited syndrome, although it can be chronic in some individuals. And on the right is a very rare sarcoidosis syndrome called Herford syndrome. And it is the triad of uveitis, which is inflammation of the back of the eye, fever, and then enlargement of the parotid gland, which is a salivary gland on the side of the face. And you can also have facial nerve palsy, which causes facial droop. I also want to emphasize that in addition to being heterogeneous from an organ standpoint, sarcoidosis varies from person to person in terms of how long it lasts and how severe it is. So if you have a diagnosis of sarcoidosis and you're newly diagnosed, about 50% of people will resolve without the need for treatment within 2 years. An additional 10 to 15% of people will resolve without the need for treatment within 3 years. And the remainder of 1/3 to 40% will have what we call chronic disease. And when you do have chronic disease, that means a lot of the time you do require treatment. Now, the factors that are associated with self-resolving disease versus chronic disease are listed on the left and the right of this slide. Looking at the right of this slide, patients who tend to present younger, so in their 30s and 40s, those that present pretty asymptomatically, for example, if their sarcoidosis was diagnosed when someone incidentally found it on a screen for coronary artery disease, for example. Lofgren syndrome, as I mentioned before, is associated with this self-resolving type of sarcoidosis. And in contrast, individuals with chronic disease tend to be more symptomatic with shortness of breath. They'll tend to have more dramatic changes on their pulmonary function tests, abbreviated PFTs, and also their chest imaging may show some more progressive signs of sarcoidosis as well. So when you are talking to your provider and talking about treatment, you and your provider should be thinking about 3 things. And this combination of 3 things should help you guys decide if you need treatment. The first is quality of life. Is your sarcoidosis really impacting your ability to be happy, have your daily function intact, do the things you want to do in your life? Disease severity is the next category about determining if you need treatment or not. And when I say disease severity, that is a bit of a subjective term, but what I mean is that are there signs of organ inflammation that can cause permanent scarring if you don't have treatment in place? And then finally, organ involvement itself can be an indication for treatment. For example, something that's asymptomatically seen on chest imaging is not often treated, but something that is seen on the brain or in the heart is more likely to be treated. So it's really this combination of factors that you talk about with your provider that will help you determine if treatment is, the right decision for you. I want to show you this graph because it's from a paper that I think is very relevant for patients to know about. And the title of this slide is that outcomes that matter to you may not always be what the doctors are thinking about. And that's our bad. Patients really tend to care about things like quality of life and functionality and survival, whereas sometimes doctors, myself being one, admittedly can focus on more objective number things like blood tests and pulmonary function tests. So looking at this graph, there was a survey of patients and they were asked to rank what outcomes in their disease mattered most to them. And the lower a number is, the more it matters to someone. And the higher the number is, the less it matters to someone. So as you can see on this graph, quality of life and functionality and survival were rated as mattering a lot, whereas these more numerical markers that might be followed in clinical practice, such as blood tests or pulmonary function tests, seem to matter less. Now, that doesn't mean that one thing's important and the other thing's unimportant. I think what it means is that it's very important for shared decision making to be a really big part of treatment decisions in sarcoidosis. So your provider has some expertise they're bringing to the table, but you are the one living with the disease as well, and you can judge how the disease is affecting your functionality and quality of life. And it's that partnership that should, help come up with a treatment plan. So moving on to types of immunosuppression, I've put the 4 big types of immunosuppression into buckets. So you have glucocorticoids, conventional DMARDs, which stands for disease-modifying anti-rheumatic drugs. I will just call them DMARDs. You have targeted DMARDs, and then you have biologic agents. So looking at glucocorticoids, I think that the majority of you who have gotten some sort of treatment for sarcoidosis has probably seen this class of medications. So this includes most commonly prednisone, methylprednisolone, dexamethasone, and betamethasone are some other types of glucocorticoids. And these are very strong medications that quickly reduce inflammation and calm the immune system down. They work fast, which is great, but they can have side effects if used too long because they have a lot of off-target effects in addition to suppressing the immune system. Conventional DMARDs include medications like methotrexate, azathioprine, leflunomide, mycophenolate mofetil, and hydroxychloroquine. And these are oral medications that change the way your immune cells multiply. So a lot of times they will interfere with the building blocks of immune cells to decrease your level of immune cells and inflammation. And because these medications are acting in a wider manner and a slower manner, they are, more gradual and take a longer time to take effect than steroids, but they can be very effective in reducing sarcoidosis inflammation. Targeted DMARDs are mainly this class of medications called Janus kinase, also known as JAK inhibitors. These are oral medicines that block specific pathways in the immune system that are responsible for causing inflammation. And then finally, biologic agents. These include TNF-alpha inhibitors, tocilizumab, and rituximab are very large molecules. And so that's why these medications aren't typically given orally. They have to be given via injection or via an infusion. And they're also very specific molecules. They bind to specific parts of the immune system, either proteins or cells, and they are very powerful agents as well. So a quick word on glucocorticoids. This is actually the only medication that's approved by the Food and Drug Administration for sarcoidosis, which is frustrating because I think it speaks to, the lack of large trials in this field that allow the FDA to really push medications forward that are alternatives to glucocorticoids. That being said, we're doing the best we can to expand our clinical trial basis, which I'll talk about at the end of my presentation. But the strengths of glucocorticoids are that they work fast. They're very effective in reducing the inflammation seen in sarcoidosis. They're cheap and they're very easy to take. They have good oral bioavailability, which means they're pretty easily absorbed in the GI system. But as many of you know, there is a catch. Patients with sarcoidosis on glucocorticoids are more than twice as likely than those without glucocorticoid use to get diabetes, gain weight, develop hypertension, high cholesterol, low bone density, and eye disease such as cataracts. And also, these glucocorticoids are associated with decreased health-related quality of life and increased healthcare utilization, primarily in the form of emergency room visits. So even though they have some pros, in my opinion, a lot of times they are very outweighed by all of these toxicities. Before I get into talking about some of the DMARDs and biologics I listed a couple slides ago, I want to say some general words about how to prepare for DMARD therapy and how to monitor for safety events while on DMARD and biologic therapy. So when your provider is initiating either of these medications, they'll generally be testing markers of infection before initiation, most commonly hepatitis B and C, HIV, and tuberculosis testing. And that's because some of these immunosuppressive agents can reactivate dormant viral infections or dormant tuberculosis infection. So if you're found to have one of these that is not an active infection but a dormant infection, then you will get most likely some co-treatment for this infection either before or while initiating one of the agents. It's also very important to talk to your provider about vaccines before you start some of these immunosuppressive agents. And that's because one, the agents will increase your risk of infection, so it's good to be protected against them. But two, because the agents are quieting your immune system, many of them often blunt your response to vaccines. So ideally, before you start these medications, you will try to get as many vaccines as you can to have the best immune response to them. And then in terms of lab monitoring, every provider feels a little bit differently about this. But in general, you will need to monitor your cell counts and your chemistries, including your kidney function and your liver function, while on this type of immunosuppression, the DMARDs and biologics. And the lab monitoring typically entails baseline labs and then every month for the first couple months. And if those are stable, then every 3 months to every 4 months. A few special considerations. If you're starting azathioprine, your provider will order something called a TPMT, which is an enzyme that helps check to see if you're metabolizing the azathioprine correctly. JAK inhibitors and tocilizumab cause increased cholesterol as a side effect. So your provider will often order a baseline lipid panel and a lipid panel every so often, every 4 to 6 months. And then rituximab can cause an immunodeficiency, which is low immunoglobulins. And so you'll typically order baseline and frequent immunoglobulin checks while you're on rituximab. I also want to touch on cancer risk with DMARDs and biologics. As a rheumatologist, that is really one of patients' biggest fears about initiating these medications, and I totally understand that. Unfortunately, this is a controversial topic, so I'm just going to put out a disclaimer that this is my stance and my appraisal of the evidence, and your provider may feel differently, but this is how I practice. So theoretically, there is an increase in the risk of cancer with immunosuppressive agents, and this is because cancer cells are often destroyed by the immune system before they're able to replicate and kind of cause the cancer that's able to be diagnosed. So the thought is that if you're quieting down your immune system, that cancer cells would be able to, escape the immune regulation and then multiply. But, in the literature looking at cancer risk and biologic therapy and DMARD therapy, this theoretical increase in risk hasn't really played out the way you would think it is. And there are many conflicting results as well. And then finally, studies in these areas often look at patients who don't have sarcoidosis. So they look at patients with rheumatoid arthritis very commonly. And that's just not the same as the disease that you have. And so it's hard to extrapolate data from one disease to another. That being said, there is a significant but small increase in the risk of skin cancer for many of the DMARDs and biologics. So I tell all of my patients who are starting these medications to get a yearly skin check with a dermatologist and use a high SPF sunscreen. And I also tell them that sarcoidosis in and of itself is a chronic inflammatory disease that increases your risk of cancer just from chronic inflammation, not substantially, but increased. And if immunosuppression further modulates this risk, then all the more reason to get age-appropriate cancer screenings as determined by the United States Preventative Task Force or the American Cancer Society. And then the one exception to all of this is that JAK inhibitors, which I'll speak about briefly, do have systematically been found to increase cancer risk. And this data was in individuals who were aged 50 or older. So for people that I'm starting a JAK inhibitor on, we'll have a particular discussion about this risk. So now I'm just going to go one by one and quickly talk about these medications. So I'm going to start with methotrexate. It's a very common medication used in sarcoidosis, and it blocks replication of immune cells that cause inflammation. It's effective in multi-organ sarcoidosis, and it comes in either a pill or injection form, which is taken once a week with folic acid. The most common side effects are fatigue, and this typically comes in the day to 2 days after taking methotrexate. Other side effects include GI side effects like diarrhea. You can get mouth sores, hair thinning, and abnormal labs, and it does suppress your immune system. Because it can cause liver injury specifically, we tell our patients to avoid alcohol while on methotrexate. Different providers feel differently about, whether you can make an exception to that rule, every month or for a special occasion. I say generally avoid it, but you don't have to have zero alcohol ever. And, it's a nuanced topic, but it is in general avoided, alcohol that is. It also is very teratogenic, so any patients that are of childbearing age should either be on multiple forms of birth control or not be on methotrexate. Leflunomide is essentially a cousin of methotrexate. It acts very similarly. It is used less commonly in sarcoidosis, but it has a similar side effect profile and similar considerations, especially the teratogenicity. So I'm going to just move past this one. Azathioprine is also quite similar to methotrexate in that it blocks replication of immune cells. It's used in multi-organ disease and comes in pill form. In terms of possible side effects, pancreatitis is a very rare but noted side effect that can occur with azathioprine. The rest of the side effects are shared with methotrexate, so fatigue, nausea, GI side effects, abnormal labs, and infections. Next is mycophenolate mofetil, which just like the others, blocks replication of immune cells. It is used in multi-organ disease, and it comes in pill or liquid form. And importantly, it also has a coated form that's called mycophenolic acid. The reason that there is this coated form is that the biggest side effect of mycophenolate mofetil from patients tends to be diarrhea and GI intolerance. So if a patient doesn't tolerate the mycophenolate mofetil, often I will recommend mycophenolic acid instead. And this medication is dosed twice daily, which is really hard to take medications more than once a day. But unfortunately, the way that this drug is metabolized, you need to be taking it twice a day or it's not effective. And so that's something to consider too if you're someone who, forgets pills in the evening. Hydroxychloroquine is not an immunosuppressive medication, it's an immunomodulatory medication. And so what that means is that it alters the immune system just a little bit by interfering with immune cell communication. And so it actually doesn't increase your risk of infection, which is great. It tends to be used for milder disease, typically skin and joint manifestations. It comes in a pill form. And the biggest side effect of hydroxychloroquine is that there is a small but significant chance of retinal deposits that can build in the eye over time. After about 11 years of consistent use of hydroxychloroquine, the risk is about 15%, is what we found in our Hopkins lupus cohort. So, for that reason, we tell everyone on hydroxychloroquine to get an eye exam once a year. So moving on to the targeted DMARDs, this is the JAK inhibitors class of medications. So these are a class of medications that block immune signaling, not immune cell replication. And they are used for different organ manifestations of sarcoidosis, but this isn't typically a first or even second line agent. This is typically for patients that have had particularly challenging disease courses and a lack of response or intolerance to multiple medications. And, the side effect profile, I think, is the most challenging part of, taking this medication and being excited about taking this medication. There is an increased risk of cardiac events, cancer, GI perforation, diarrhea, skin reactions, and then abnormal labs and infections. That being said, if a patient does require this medication, uncontrolled sarcoidosis inflammation in certain situations can be a higher risk than this medication. So, we do recommend it in certain cases. The next group of medications are called TNF alpha inhibitors. So this is a very common class of medications used in sarcoidosis, and they are in the biologic class of medications. So they are specifically blocking TNF alpha, which is a molecule that's very involved in granuloma formation and inflammation, which is the hallmark of sarcoidosis. They're used for many different organs in sarcoidosis, but are particularly effective for the neurologic system, for the eyes, for the skin, and often for the heart as well. They can be given in an infusion or in a subcutaneous or pen form. And they're well tolerated. The side effects that you'll often talk about with your provider on the first visit where you discuss this medication is that they can exacerbate heart failure in certain cases. They can cause neurologic disease very, very rarely. They can cause something called drug-induced lupus, abnormal labs, injection site or infusion reactions, and then finally they increase the risk of infection. Tocilizumab is another biologic that blocks a specific part of the immune system called interleukin-6, and it reduces inflammation in the immune system by blocking this molecule. It's being increasingly used in multi-organ sarcoidosis, and again, like for JAK inhibitors, it's typically reserved for diseases that have been particularly challenging to get under control. It can come in a subcutaneous form or an infusion, and the possible side effects include GI perforation, diarrhea, injection site or infusion reactions, abnormal labs, or infections. I am going to skip over rituximab because it's very uncommonly used, except sometimes for neurologic disease. If someone wants to ask about it after, I'm happy to answer more about it. And IVIG, I will briefly talk about because it has a lot of popularity in small fiber neuropathy. This is essentially a pool of antibodies from healthy donors, and it helps modulate the immune system and reduce inflammation. It's typically an infusion given once a month, although there is a subcutaneous form that's given every 2 weeks as well. And the biggest side effects from IVIG are headaches and fatigue with the infusions. You can also get allergic reactions, and then rarely you can get blood clots or abnormal cell counts or kidney function. So I know this was kind of a marathon through the medications. I do want to plug two websites. One is the American College of Rheumatology, which has wonderful patient education handouts about a lot of these medications that we discussed. And then the second is the Patient Advisory Board organization at Hopkins has made a website called saysarcoidosis.org that has patient medication education as well. I unfortunately seem to be running out of time, so I'm going to quickly go through some of these treatment guidelines. And so this is just to say that, a team of sarcoidosis experts in 2021 did publish clinical practice guidelines on how to treat sarcoidosis. And similar to what we talked about earlier, they agreed that treatment should be dictated by someone's overall risk of having disability, having irreversible organ damage, and having reduced quality of life. They decided that steroids are first line for moderate or high risk patients. And then if you're unable to taper off of steroids in 3 to 6 months, or there are unacceptable side effects, then steroid sparing therapy is recommended. And so I won't go through these proposed guideline flowcharts for these different organ systems. I think the main takeaway here is just to remember that when we're making treatment decisions in sarcoidosis, we are often looking at what organs are the most impacted and deciding based on that. So in pulmonary sarcoidosis, you start with steroids, methotrexate as a go-to afterwards, and then you can think about medications like TNF inhibitors, or in more refractory cases, a JAK inhibitor or rituximab. Cardiac sarcoidosis, you're typically co-treating initially with with a DMARD and steroids. And, for more refractory cases, you can think about a TNF inhibitor. And then for neurosarcoidosis, again, you are treating with steroids and you can move on to steroid sparing therapy with DMARDs or a TNF inhibitor as well. And then for small fiber neuropathy, a lot of times you can use some non-immunosuppressive agents such as lidocaine and lamotrigine and carbamazepine. But for persistent symptoms, IVIG or TNF alpha inhibitors are kind of go-tos. I will say these treatment guidelines are pretty controversial in the sarcoidosis community. And a lot of this is because, many of these recommendations are of low evidence basis. And so they're really expert opinions. And that's hard because different people feel different ways about what is the best way to treat a specific organ manifestation of sarcoidosis. At Hopkins, we have a particular way of approaching it. We tend to start with prednisone and, co-treat or treat very close after starting prednisone with methotrexate, azathioprine, or mycophenolate mofetil, and we use TNF alpha inhibitors next. And these are kind of a list of other agents that we use, most of which I briefly mentioned before. I want to end by saying that there may be a shifting paradigm in how we think about how we treat sarcoidosis. So this was an article in the New England Journal of Medicine, which is kind of the most famous medical journal for physicians. And they published an article about sarcoidosis, which is exciting because we need the medical community to, have more awareness and have more enthusiasm about sarcoidosis research. So that was great in and of itself. But the other exciting thing about this project is that, they were testing whether you could treat pulmonary sarcoidosis with methotrexate first instead of with prednisone first. And so this was a study from the Netherlands where they looked at over 130 adults with untreated sarcoidosis, and some of them were started on prednisone, whereas the other were started on methotrexate. And the idea was to see whether methotrexate was non-inferior to prednisone, and to see kind of the side effects from both. And what they found, if you look on this graph, you see this line graph where prednisone is in the dark blue and methotrexate is in the light blue. And what this line graph is referring to is the change in lung function over time. So as you can see, prednisone group has a big increase in lung function at first, but then that effect kind of levels out over time. And by week 24, so the 6-month period, it's about the same as methotrexate. So it's almost kind of like the tortoise and the hare. If you guys are familiar with that children's story where prednisone is the hare that gets to the finish line quite quickly, but then kind of slowly progresses to the end, whereas methotrexate slowly but steadily catches up. And the adverse event profile was also pretty similar in terms of the patient-reported events. So, even though this was just in the Netherlands, it just looked at sarcoidosis in one organ for 6 months. It's exciting to me because I think it shows us that maybe we don't need to be relying on steroids as much as we think we do. And I think there's more to come for that. So stay tuned. And with my last slides, I am not going to go through all of these trials that are going on in our center, but just a plug to say that, even though the treatment landscape can feel a little bit limited at times, there are so many active efforts to expand our options for treatment in sarcoidosis. So we have these 3 different trials going on in our center right now. And then additionally, in other centers, there are trials for lung disease, cardiac disease, and skin disease and sarcoidosis. So that's all I have today. We talked about, that the decision to initiate immunosuppression and sarcoidosis should really be shared decision making with your provider. It depends on the quality of life you're experiencing, what organs are involved in your sarcoidosis, and whether you have scarring or risk of permanent damage from your disease. The classes of immunosuppressive agents in sarcoidosis you can think of as steroids, conventional DMARDs, targeted DMARDs, which include JAK inhibitors, and biologics. Current treatment guidelines suggest that you should start with steroids and transition to other agents for long-term control, but this paradigm may be shifting. And then finally, just to end on note of hope, there are many clinical trials of novel treatment agents that are underway. So thank you guys for listening to me. I'm happy to answer any questions I can about immunosuppressive treatments and the disease.
Thank you, Dr. Mathias. Thanks for sharing that valuable information. We're going to now open the floor to questions that were sent in earlier from our audience, as well as some new questions that just came up on our Q&As. So let me start with, if you have F3S3 and CKD, what is the best course of treatment?
F3S3?
F3S3.
Uh,
Fibrosis 3, I guess stage 3, grade 3, and scatting stage 3.
Scatting stage 3 sarcoidosis and CKD, what is the best treatment? Is that the question?
Yes.
Yes. Okay. So, I think it would go back to that 3-pronged paradigm. What is your quality of life? Let's assume that it's affected by sarcoidosis pretty profoundly. Scatting stage 3 tends to imply that you have pretty active disease that's at risk for scarring. And then, what organ is involved? So it seems like the lungs are involved. And plus or minus other organs may present a more compelling case for treatment. But let's say you're just focused on the lungs alone. Methotrexate tends to be avoided in kidney disease, so I wouldn't be thinking about that agent. Things that I would be thinking about include azathioprine, possibly mycophenolate mofetil, and depending on if you have other organ involvement, you could also think of a TNF inhibitor. Steroids could also be added to this, depending on what your acute status is and if you needed kind of some help in the short-term setting with your symptoms. I would try to get you on as low of a dose of steroids as possible, kind of for a long-term treatment plan. But those are kind of the initial thoughts. It's always hard to come up with a hypothetical answer because these decisions are really complex and have to be made with the interaction with the patient as well.
Thank you very much. Next question, can you touch on the benefits of using Humira to treat sarcoidosis?
Yeah, so adalimumab is a TNF alpha inhibitor, and it works particularly well for certain manifestations of sarcoidosis. So, ocular sarcoidosis, specifically uveitis, cutaneous sarcoidosis, and then joint sarcoidosis, sarcoidosis arthritis. I'm reaching for adalimumab or infliximab, which is kind of a cousin of adalimumab first. It also has some efficacy in pulmonary sarcoidosis and cardiac sarcoidosis and neurosarcoidosis and small fiber neuropathy as well. So if someone has multi-organ disease, adalimumab will be one of the first things I'm thinking about. And it's nice because it's given via a pen form, so it's not an infusion like the other TNF inhibitor, infliximab, that's used in sarcoidosis. So it's kind of a effective agent, but also a convenient agent and has multi-organ efficacy. So I'm thinking about it quite often in my practice.
Thank you again. Next question, how do you avoid building antibodies to Humira? And are there biologics beyond Humira, Remicade, that show promise?
That's a great question. And that's actually one I didn't touch upon in the talk. So, just for anyone who's not familiar with this concept, biologic agents are often formed from foreign particles that are engineered to bind to specific cells or proteins. And so it's very possible that your body recognizes them as foreign objects and then makes antibodies to them, which kind of neutralize and nullify the effect of the drug. So to overcome this issue that occurs quite frequently with infliximab and somewhat frequently with Humira, we'll often pair the biologic with a DMARD at a lower dose. So we will give Humira with a low dose of methotrexate or infliximab infusions with a low dose of methotrexate or azathioprine or even mycophenolate mofetil. So that's the first part of the question. The second part of the question, are there biologics apart from Humira and infliximab? So tocilizumab is definitely something we use in our center as kind of a third line biologic. JAK inhibitors aren't strictly a biologic, but we're thinking about them as well. And then it also depends, again, not to sound like a broken record, but what organ is involved. So if it's primarily neurologic disease, I would think about rituximab. Cyclophosphamide is a very, very potent agent that I actually didn't even talk about on this slideshow because it's used so uncommonly. But that would be a biologic that we could think about if the disease was very, very severe and extensive. And in terms of other agents, there are the clinical trials of biologic medications that are still underway.
Thank you. Next question is, what are your thoughts on patients with sarcoidosis using GLP-1s?
That's a great question too. It is gaining a lot of popularity, and I think there's kind of a GLP-1 revolution in healthcare, and there's so much data that's showing its benefit in diseases beyond obesity, and I'm suspicious that sarcoidosis, it's also beneficial as well, but we don't have the data to support that. So right now we are pretty liberal in telling our patients that they should be on GLP-1 agonists because a lot of times the medications that we're prescribing, namely prednisone, cause weight gain, or your sarcoidosis is not allowing you to exercise. And so GLP-1 agonists can help, reduce the weight that you have put on from, effects from sarcoidosis treatment or sarcoidosis itself. And there's a thought that there might be a metabolic anti-inflammatory component as well, but we don't have the data yet to support that.
Thank you. Next question. Why do some doctors prefer biologic medications instead of steroids? In my experience, the biologics are more dangerous.
Yeah, that's a really good question, and I think that's a concern of a lot of patients. And I would say as a rheumatologist, I am pretty um I was going to say the word hateful, but pretty wary of steroids because I think that um one of my colleagues calls them the devil's candy because they can make you feel really good. They're cheap. They work very quickly, but they just have so much toxicity over time and it's multi-organ. And, a lot of this toxicity is irreversible. Weight gain, for example, you may be able to lose weight, or hypertension that may help get better, or hyperglycemia that may get better when you go down on steroid dose. But things like bone density loss, avascular necrosis, where you have essentially an infarction of your bone tissue, which is very painful, high cholesterol, heart disease, all of these things, are less reversible. And so I think that it's really good to use medications that allow you to come off of steroids and have, decades of safety data behind them as well.
Thank you. Are these treatments lifelong or can they be stopped once the symptoms improve?
I'm glad you asked that. That is something I wanted to get to in this slideshow, but clearly I didn't have enough time. Treatment discontinuation in sarcoidosis is tricky. I don't think we have great longitudinal data about that. I will say, it goes back to this 50 to 60% of patients have self-resolving disease. If you are in that bucket where your disease is kind of in remission within 3 years and you don't have any sign of disease activity, then the answer is quite easy. You just taper off immunosuppression, continue to monitor several times a year, or if anything comes up, and you just, go on without immunosuppression. What gets a little more difficult is patients that fall in that chronic disease category. We tend to think of immunosuppression more as a chronic part of their medication regimen. But it is possible if someone has, prolonged disease quiescence that you can start tapering immunosuppression. I would never, take it off all at once. But I would, space an injection or, take a pill every other day or half the dose. I think that tapering and seeing, how your disease activity responds is something that is very reasonable after a certain amount of time.
Thank you. Next question. What strategies do you find most effective in minimizing infection risk and other long-term side effects?
Yeah, that's a great question as well, and one that comes up a lot with patients. I would say preventative measures like vaccinations are so, so important. Vaccinations can protect you from the infection and just make the infection less severe if and when it happens. In terms of masking, that's often a decision that's pretty personal to a patient. I will counsel a patient based on their disease activity and based on the immunosuppressive agent used. So for more powerful medications like rituximab, for example, or if someone has, pretty substantial lung disease where a lung infection would be really hard for them to recover, I will tell them to wear masks in places like airplanes or crowded public spaces during flu season or during the fall, where the risk of infection is a little bit higher. But it's just very hard because everyone has, a different value system. And I think I just encourage patients that whatever makes them feel comfortable about their own infection risk when it comes to masking, they should do, but that they should generally think about masking on planes.
Next question. What type of labs are considered abnormal? If you can provide some examples.
Yes. So I would say that depends on the immunosuppressive agent that you're using. I'm looking out for particular things. So let's take methotrexate, for example. Methotrexate, I am looking for at the cell count. So I'm looking at the white count because it can cause a low white count called leukopenia. I'm looking at the platelets and the hemoglobin because it can cause decreases in those as well. And then I'm importantly looking at the liver tests because liver injury is a common mechanism of methotrexate toxicity. And I'm looking at the kidney function as well because methotrexate isn't recommended or is recommended to be dose reduced in certain levels of kidney disease. And so each of these biologics or DMARDs have different things I'm particularly looking at. But in general, if you're getting a CBC, which is a complete blood count, and a comprehensive metabolic panel, which looks at kidney function and liver function tests, then you should be kind of examining the big players that might be affected by these immunosuppressive agents, with the one exception being that JAK inhibitors and tocilizumab, I'm also getting lipid panels since both of those agents also cause high cholesterol.
Thank you. Next question, should I avoid certain foods, supplements, and alcohol?
Yeah, so, we had a patient event a couple weeks ago, if any of you guys were able to join it, and that question came up so much. And so it's something that, patients really care about, and we're trying to actively research it as well. Right now, we can borrow conclusions made from the rheumatology literature, which have shown that, a Mediterranean style diet is quite anti-inflammatory. So a Mediterranean style diet is leafy greens, avoidance of red meat, fish, nuts, and whole grains. And that seems to be a good one in terms of reducing overall systemic inflammation. Plant-based diets have also, become popular as well. Um, so I think I would say those two are kind of the big ones.
Thank you. Next question, which investigational therapies do you believe hold the most promise for improving treatment for hard to treat sarcoidosis?
That is a great question. I think if you asked 5 different sarcoidosis experts, you'd get 5 different answers. Um, you know, Practically, I think XTMAB, which is also called Zentria, is one of our clinical trial drugs that I think probably has quite a bit of promise, and that's because it's structurally very similar to infliximab, which has demonstrated pretty wide efficacy in sarcoidosis. So I think realistically that has a good chance of showing positive results. Thinking about the mechanism of sarcoidosis, I like the idea of JAK inhibitors because they target a lot of molecules that are specifically involved in the granuloma formation. Same with tocilizumab as well. But that's kind of the $1 million question. How do we come up with an agent that's kind of specific for sarcoidosis inflammation that isn't something that just works like in 15 to 20% of patients?
Thank you. Do you have a treatment plan for tapering off of prednisone?
Yeah, so that will depend on the provider. I think I'm a little more aggressive for better and maybe for worse sometimes about tapering off of prednisone as a rheumatologist. Prednisone, the nice thing about it is it's very fast acting too. So if you realize that you've tapered too quickly, you can always kind of restart it. But in general, I kind of think about the organ manifestation, and I try not to keep patients on prednisone for over a month. But there are exceptions to that. Some people, have a lot of medication intolerances or have particularly challenging diseases and will require some chronic prednisone. For those patients, I tend to try to make it the lowest possible dose that they will tolerate without having disease flares or quality of life decrements.
Thank you. Next question, are there any, and how would one qualify for experimental therapies?
So in terms of clinical trial medications, clinicaltrials.gov is the website that kind of lists all of the ongoing trials in sarcoidosis and the centers. So I would say starting with that can tell you where medications are being tested. But it would really be something to talk about with your provider because a lot of times you can be treated with something that's not investigational and has been tried and true and might work for you. And so you don't have to, be in a clinical trial either. I think it depends on your disease and what your provider thinks and how close you are to a center doing trials.
Thank you. Next question. What precautions should I take when traveling or being around other sick people?
Yeah, no, that's a great question. I think around sick people, while you're on immunosuppression, masking makes a lot of sense, particularly if you have active pulmonary disease. And then for traveling, I would say masking on planes.
Thank you. We're getting close to the end. Is moving from methotrexate to a stronger drug based more on symptoms or as soon as seen in another organ?
That's a good question. I think it would depend on both. If you are on methotrexate and disease activity is picked up in another organ, then that would imply that, methotrexate is insufficient to control the disease in whatever organ you're now picked up on. So I would say both. If you have asymptomatic organ involvement, for example, if you are incidentally found to have lymph nodes that are enlarged in the abdomen, but they have no effect on any of your labs or how you're feeling, and the methotrexate is treating, let's say, your lungs or your heart just fine, then I may not be as compelled to, switch an agent just because I see organ involvement. So I would say both.
Thank you. Last question. For bone sarcoidosis, specifically pelvic lesions, which medication would you recommend for treatment?
Yeah, that is a great question. I would say osseous sarcoidosis, so bony sarcoidosis, about 50% of patients are actually asymptomatic. So if you're in that camp, the decision of to treat or not to treat is pretty controversial, with a lot of people thinking that observation is okay. If you're in the camp to where it is symptomatic, they tend to have, there's a pretty wide variety of agents that are used. I've seen DMARDs used. I've seen TNF alpha inhibitors used. So again, I would be going back to what other organs you have involved and what are your other comorbidities as well.
Well, Dr. Mathias, thank you very much for taking the time to share your expertise and for answering so many of these thoughtful questions. I'm sure that you've helped a lot of patients, their families, better navigate problems with sarcoidosis. I also like to thank everybody else who joined us tonight, participating, engaging with us. Again, please follow us on our website. We have these at least on a monthly basis. And on behalf of the foundation, we wish you continued strength, good health, and have a wonderful